So there is a proper way. We're going to teach every person as we bring these in before we get them in to show them exactly how you line up, where you need to suction to the depth of the catheter for the baby. So if you over suction, you can bagel that baby, which is going to be detrimental to them. So you want to make sure you're not overdoing that. Over suctioning can cause bleeding, irritation in the line as well. But it is necessary because they are dependent on that tube we've placed in there for them to be able to ventilate effectively against that tube.
Absolutely. And as she said, the suction catheter and the EP tube have markings on them, and there's markings on it for a reason. So we line up those markings to make sure that we're not going into the lungs with that catheter. We are going to the end of the endotracheal tube. We're not going in. We don't want to create any damage. Those lungs are fragile, and we don't want to stick a suction catheter down into those lungs and damage them, like cause a pneumothorax or other things. So this is going to be an additional educational appointment as we go through our education blitz for the 30-weekers that we will be touching on quite a bit. So let's talk about what happens when something goes wrong.
First of all, don't panic. Number one thing is do not panic. Panic doesn't create any environment, is never going to be better when panic isn't. So if there's something that is concerning, get your RTs to the bedside with you immediately. And let's walk through the problems of what we're seeing and how we can fix that problem. In the event that this baby has self-extubated, it does nothing. They're a bit, we have a tube. It is sitting in a very precarious spot inside. It is secure, but babies have secretions. Babies' skin at 30 weeks is different. It's not as resilient and can flock and things can move. And if that tube is to come out, the number one thing is just grab your RT, grab your nurse practitioner, and we can start by bagging that baby like we would do prior to entering that AT tube in for the baby as a stable airway. And then we can get the baby prepared for reintubation if necessary. Sometimes babies extubate and we'll just leave them right on, see if they can handle NIPPV or just CPAP. Sometimes they're at that weaning mode on minimal settings. We can do that. But your RT will be there to have that discussion. Your provider will be there with you to have that discussion. Never panic. Just go right into basically a CPAP, or if you need the positive pressure ventilation, baby.
Yeah. And so I would suggest that if an endotracheal tube comes out, you are no longer in nursing management mode. You are in NRP mode. So we don't know how long we have before that baby becomes a bad blue baby. They might never, but they might right away become very, very short breath and oxygenation is poor. So we jump right to the CPAP, bagging the baby, all those things. Get your team there. So call out, hit the button, whatever you need, make sure the rest of the team arrives so that we can take care of this baby. So what are some of the clinical signs that you would see for maybe going down that bank?
So the difference between CPAP and NIPPV to the vent, which is kind of that blurry zone where we're moving towards being intubated, is respiratory drive. If we have no drive, we cannot ventilate the baby. The baby has to make spontaneous breaths. If the baby is spontaneously breathing, support with CPAP is very effective. If the baby is not breathing, it is not going to do anything to put CPAP on a baby. They're just going to continue to decompensate into secondary apnea, which at that point is automatically intubation at that point. So number one thing is assess the respiratory breathing of the baby. Is the baby breathing? Okay, we can CPAP this baby for a minute. If they're not breathing very effectively, we can start doing PPV. If they're breathing occasionally, you can do PPV with them to help them breathe. And if they just cannot breathe, that's where we choose to elect intubation for a baby. Either the lungs are not strong enough to breathe, or they have no drive. Any baby, no matter where they are, 30 weeks to term, if they're not spontaneously breathing, you have to intubate a patient, because that is the only way you're effectively going to breathe for them, is to let the machine kick in and help that baby breathe.
What kind of babies do you look at that have a secondary apnea or apnea?
Again, the smaller the baby is, the more likely that we're going to have apnea. Babies develop the ability to, spontaneously breathe effectively around 34 weeks gestation. That should be developed in that infant's brain. If there is something above 34 weeks that's happening, we're talking about some sort of neurological metabolic disorder that's happening with that baby, causing a lack of respiratory drive. So before 34 weeks, which is where we're moving down to, the smaller they get, the less they're going to breathe when they come out. So that is where we give them their triple shot of caffeine with their caffeine that we put all our babies on to help them remember to breathe. But it takes a little time to get that amount of caffeine into them to spontaneously continually breathe. So you want the 30-weekers are definitely going to have more of a trouble with breathing. They will all come out of being on caffeine for at least a few weeks before we start to wean, or a couple weeks before we start to wean them off of that. Those are your big ones that are not going to breathe other than there's some sort of neurological metabolic thing that's going on with the baby.
And looking at full terms and 34 and above, you can look at MAG babies. I have times that have very much secondary apnea. You also can look anytime that you give a mom a sedative. This is something that we do see happens frequently in our ORs, where they're giving morphine, they're giving other fiends that will cause respiratory, depression. And that's something that, we catch on NRP most of the time, but those are babies that sometimes might have to be on the med for
A
couple
couple
hours.
hours, when they wake up.
while they wake up. And those are the babies we will weep.
Yes.
So, the last topic that I wanted to bring up is ABG interpretation. I was going to let Sarah go through deep and ABGs.
So I feel like the best way that we can actually do like a full that we should have a course that, and we are happy to do that, where we can actually write a bunch of different interpretations of ABGs and VBGs and CBGs. So when we're saying these, we're talking about arterial blood gases versus a venous blood gas versus a capillary blood gas. And then you do have differences between your cord gases that come in from when you're in the OR. And those are all interpretive things. When we're doing cord gases in the OR, we're trying to see how much distress was that baby prior to coming out. Is there risk factors for this baby that could result in needing to be cooled through, at risk for hypoxic ischemic encephalopathy, HIE. So I think the best way to go through a whole course of this, arterial blood gases are always your gold standard. They are the definite definition of what is happening on an oxygenated level for that baby. The most accurate blood gas is an ABG, followed by a VBG. Capillaries, the longest time, that's the lowest circulating oxygenated blood returning to the lungs to come back. So those are a little bit more, you may have a little more acceptability for elevated CO2 levels on a CVG versus an ABG is a true look into how that baby's actually perfusing, and that's what we're looking for. So I'd like to do a course with everybody on ABG, so we could actually, what I'll do is start to provide maybe some worksheets in the units and walk through. So let's interpret this together. You have two compensatory systems that are working to balance your body. Everybody needs homeostasis, and we all sit between 7.35 to 7.45 on our pH. And your body's goal is to make us go back to that place all the time. Your lungs are one system that's working, and your kidneys are your other system that's buffering that to try to maintain you. And so we have different things that can happen. You can get acidotic, both respiratory or metabolic, depending on the underlying condition. And you can be alkalotic on both sides of that, respiratory and on metabolic. So our goal is to read that blood gas to determine which system is at fault. Is there both systems at fault? Do we have something underlying causing a respiratory issue, or do we have something underlying that's a metabolic issue and the other system's trying to get the balance? So it sounds very complicated, but once we go through, and I will provide this for everybody, some actual different types of blood gases, we will go through those, walk through them, and I think you'll find it's not as scary as people think it is when they break it down. But it is definitely a visual we'll work through together, and we can do that either on another TED Talk with you guys, which we can do right. We'll just get the board and we'll kind of put a whole bunch of different ones out there and talk about what systems are compensating, what's going on. And I think that will help. And then we'll make some worksheets in the unit so people can interpret that.
And going on with the conversation, the gold standard that she said, that arterial blood gas, it gives you the most. Everything else is going to be skewed. So the oxygen is always going to be off on a venous or a CVG. And then as you go to a CVG, you don't kind of know where the pH and the CO2 are, but it's not 100% accurate. So it'll be a good talk that we can do as a second TED Talk down the road. And other than that, that is all due for today. Thank you, Sarah.
You're welcome.
And hopefully you enjoy and learn something. Thank you. Bye.